Hello everyone, this is Matt, and I wanted to talk through the morning report topic for Tuesday, October 2nd at the University Hospital. This is a 6-year-old woman. She has a past medical history of tetralogy of Fallot, has repaired multiple repairs, and congestive heart failure with very poor RV function. Also factor V Leiden. She has a history of DVT-PE. She's on apixaban, obstructive sleep apnea and CPAP, hypothyroidism, and she originally presented to the University Hospital with severe volume overload. So I wanted to just make a note here. The next key study that she gets is a congenital surface echo. She gets a regular, like, adult surface echo, but it's less helpful in this case because of her history of tetralogy of Fallot. And so you'll see that things are described a little bit differently, but she actually has a conduit instead of a pulmonic valve, and that appeared to be very, most likely calcified, very echo bright and high pressure. So she basically had evidence of pulmonic stenosis. And a recap here, just to recall, here is a simple diagram of TOF. You see the thickened RV muscle, and then the VSD that allows deoxygenated blood to go into the arterial system. So the two main fixes are repair or shunt from pulmonic artery to brachiocephalic trunk. So this is the critically important part of this case. When she was admitted, it was noted that her phenytoin and apixaban had an interaction. And so her apixaban was stopped, and she was actually started on Lovenox injections. And so she was dosed based on her initial weight of 148.3 kilograms. And over the course of her admission over the first 2 weeks, she was diuresed significantly with a Lasix strip and metolazone, and her electrolytes were supplemented relatively aggressively. And on the 12th, there started to be some evidence of bleeding. No significant hemoglobin drop, but she did cough up a 3 centimeter blood clot and then had another later, a smaller clot, some minor nose bleeding. And they checked an anti-10A level, and it was greater than 2. At that point, they stopped her Lovenox injections. About a day after they noticed the patient started bleeding, she presented with a mild headache, and then a day after that, she decompensated acutely overnight. And the night team was paged around midnight, and the patient was essentially somnolent. It was documented that she had a RASS of -4 at that point, although she would respond to sternal rub. And they estimated her GCS at about 10. They called an RRT, they ordered stat labs, and got a head CT, which we'll take a look at in a second. And then they ordered protamine in an effort to try to reverse the effects of Lovenox. They also called a stroke code and notified the neurology team. So here is a look at her CT scan, and you'll note right away the bright spot, evidence of acute hemorrhage, and essentially it occurred at her posterior fossa, and there was actually enough bleeding to cause a mass effect with some ventriculomegaly in the supratentorial system. So a quick note on reversing Lovenox. There aren't really too many good options. You'll see here actually an in vivo study, but with mice, about bleeding times. And essentially, protamine is more effective at reversing the effects of bleeding on heparin than it is low molecular weight heparin. And that was proven in some animal studies, where you'll see that even after protamine on enoxaparin, there's still just as much bleeding. This is a tough case because you essentially have a patient that's anticoagulated, has a history of clot. You think you're doing the right thing by switching her anticoagulation based on a drug interaction, and you ultimately end up overdosing her because you overestimated her weight, most likely. And you started dosing her at her fluid up weight, and her more euvolemic weight was much lower. And the result was ultimately catastrophic, and the patient died about 12 hours after this bleed had started. So the note really is that it's incredibly important, especially when you're diuresing a patient, to really note the creatinine, keep a daily eye on the creatinine and the weight, and you may have to make adjustments to Lovenox dosing based on that on at least a day or every other day basis. and that protamine is the drug of choice. There aren't really too many other good options in terms of reversal, but its effect on reversal of anticoagulation with enoxaparin is incomplete compared to its effect on heparin.